Wait, what
We
was
want
that?
to, we're ready to go into supine
Go
now.
that way, so we can roll this.
Yeah.
No, because you don't want to go towards opposite of the ventilator.
No,
That means the
it's
whole
back.
ventilator. So what you need to do is bring shoulder back down. Pillows come out.
Come on.
Boost to the top to rotate the head towards the ventilator again.
I'm dancing.
Okay, 1, 2, 3.
And pillows can come out here now. We're bringing her back down.
1, 2, 3.
Okay. Leads come off. A-line comes off. Whatever you need to detach. Any IVs you can get rid of.
Sorry about that.
Arms are fully extended with palms up and hands underneath her hips, close to her body. We're re-padding her with what we need for back to supine.
Yep.
And so we at least had that the whole time.
So you always want to have your head facing towards the ventilator for proning or deproning, okay? So now we're going to do the opposite, but which way do we need to move her?
We have to come this way.
Right, because we're going to go that way, exactly. So we're going to boost over to the side.
1, 2, 3.
Okay.
And tuck.
Now we're tucking
Tucking.
underneath the bottom sheet, rotating her onto her right side.
Yes, that's it. Okay. 1, 2, 3.
Ventilator group is grabbing that bottom sheet now. And when you're ready, pulling into supine.
Okay, ready?
1.
And the opposite group is lowering the descent, slowly. Good. Everything comes off. So at this point, now we're back into supine. So in theory, we should be in prone for 18 to 20 hours with every 2 hours rotating head and neck. Head is always towards the armpit. So we're always smelling the pit. That's the proper way of having head and neck. We don't want this, okay? And then an issue with our guy downstairs, they couldn't rotate his neck because they weren't boosting him high enough with that other bed. It was a hard block there, and we didn't instaflate. That's the other cue too, is if it's easier, instaflate your bed. It gives you a firmer surface to rotate. Right here is instaflate. Whenever you're boosting and turning, you can do it. You see, we did it without it, but this gives you a firmer surface to move people. Just put it back where you need it. So now we're in supine. So what happened was they couldn't rotate the head and neck, and so they left him in that position. He was there for 2 hours, needed to rotate back, but they couldn't get the head and neck that way. They didn't boost up high enough to rotate, and so it was someone who hadn't been through this before. So the nurse question was, should I then for 2 hours bring that arm down? Now neck is still here, and bring this arm up. Absolutely not. But if you're stuck, you can bring this arm up and down for 2 hours. Just don't bring that opposite arm away from the head, up and down. Okay? But this is the trick. Boost, you have plenty of room off the head of the bed, then you should be able to rotate, unless we have a problem with the neck. Okay, so now we're in supine. Now you're checking skin. These can all come off briefly. They can go right back on, because maybe in 4 hours to 2 hours later we have to go back and we should be able to use these. But check the skin completely. If physical therapy is here, we're coming down to do a full range of motion assessment, because things could have happened. Or nursing has to do a range of motion. We want to make sure the shoulders haven't subluxed or dislocated. So and then Lennards go on. 2 of them only when we're paralyzed. Otherwise it should be 1 alternating. So because it's a short window, it's 4 hours they're on until we go to prone. So patient would be reassessed by the physician. Are we going back into prone? But we've had patients, 2 weeks, 3 weeks that we proned? So it could be a short period if it resolves, or it could be a long period of proning process. And that's where we've learned the most and had mistakes and have learned from them. Are you missing anything? Face cream. So remember, before you go into prone, you're slathering the patient with barrier cream. What's it called?
NutriShield.
NutriShield should be on the patient, and even in prone, you may have to reapply every time you rotate the head and neck, and make sure the eyes are taped with, and we have special eye closures to put on
Are those
as
ones
well.
from the OR? Is that where you got
I
them
think they're from M6.
For 6. We also are going to put ointment to the eyes every 4 hours as well too, just because they're paralyzed, so just FYI.
So,
Just let goes up.
okay.
Question,
Yes.
so you had initially said that we're seeing more ECMO and started.
Correct.
This is going to be the first step prior to ECMO.
Right.
How long is that duration?
It-
Before does it depend? Totally
So what
depend?
will happen, I'm not sure how often they'll have to be prone, but from my understanding is they have to fail proning to then go to ECMO.
To go to ECMO.
So if we're not seeing results with proning now, how often we're gonna have to prone before, let's say it's a failure, I'm not quite sure. I don't know if you guys know at all. So that's the theory, is that we're gonna be cannulating people in the SICU. So if a patient fails prone in the MICU, they would then be transferred to the SICU, they would be cannulized, and then sent off to New York. Because they're not staying here for ECMO, from my understanding. But they will be started
So
here.
we're just
Yeah.
starting it
Correct.
initially.
Correct. And that will happen in the SICU.
You made a comment that if someone's neck was to get stuck to one side and they can't rotate the neck back, you said you can continue to do the change in arms here. Is there
Right.
anything we can do on the left arm for range of motion, or does that have to sit there for the next 16 hours?
That's not much. I mean, you might
can
be able
do.
to rotate it off the side, but yeah, I don't want it up at all. So, and someone asked, should we do range of motion when they're in prone? There's really no need to. I mean, if you do a once full body range of motion once a day, it should be really done when they're supine.
What are the range of
'Cause-
motion exercises you want us to see done when they're in the supine?
So, I mean, just everything normally that you would do for any flaccid patient, full range of motion of all their joints. So I can give you a whole list of things to do, but it shouldn't be anything that you all don't do with a normal bed, changing their, looking at their shoulders, making sure they have elbow flexion, bending their knees and hips, and making sure that their ankles are at least at neutral. So it's nothing that you guys don't normally do with all of your patients, it's just to relook at it specifically. And get physical therapy, call them during the day, we're in supine, can you come down? So that we can look at them. And we're here every day. Just we're not here at night. So if this has to happen after 4 o'clock, then an assessment needs to be done. Or should be done. Am I missing anything? Venodynes should be on prone or not prone. So all the time, so once we get them in position, Venodynes go back on, but make sure the hard pieces are really posterior when they're prone, but it's still anterior. So it would be opposite, but still upright. We don't want them downward. Am I missing anything else?
So we're looking at a minimum of 8 people every time we do this.
Depends on the size of the patient, and then again,
I was
as you
gonna say,
do.
they're not her size, usually they're,
Right. So you want as much
Yeah.
help in there as possible, and that's where, this is new to everyone, so just because you're doing it doesn't mean you don't pull in a nurse down the road who has done it 4 more
Yeah.
times, getting in there to have that experience. So get as many people in there. You can call orderlies too, if that's
Yeah.
available to you. But Therese and I have done it with me, a respiratory therapist, and 3 orderlies. So as long as you have muscle power and safety, we need nurses there, we need respiratories there, but then you need muscle.
And the orderlies have been trained on how to do all this? No.
Some of them have had the experience, but they haven't been in routinely.
Right. So for this session, we've done 3 and 3, but typically you can do 2 and 2 and 2 at the head. We have found that you do have to have 2 people. They don't necessarily need to be respiratory therapists. One has to be respiratory for the ET2. Another one could be an LNA or nurse, anybody, but you do need that second person just to hold their head, because sometimes you can't hold their head and turn the tubing, especially, trays you can, but there's other people that you do need 2 separate people. So we found 2, 2, and 2.
Yeah.
Definitely, bigger they are, you might need more, but at least a minimum of probably 6.
Will we be using the triodine at all anymore?
No.
No.
We're trying to not, because there's no sense in using the Triodine because we don't use any of the features that are for proning. But when you call for a Citadel bed, please don't call and say it's for proning because they're going to argue with you and say they want the Triodine bed. But we want to start using we would just want a Citadel bed for this patient. Because I think that's the best way to get around it.
Now, is the PT department open to us calling you guys?
Yes.
To come and help?
So that's what we're trying to get away from, that we shouldn't be part of that process of proning.
Of actually proning?
We
but
want to be there to do an assessment, and if we're available, yes.
Sure.
But that's where we're trying to get the nurses more in tune to this, so that a PT doesn't have to be there every time we're turning and going back to supine.
Right.
We're happy to help if we're available, but we're not always available. If we
So
have
once we're
patients.
prone, how
Right.
long do we stay?
So you're prone for at least 18 to 20 hours, and usually in supine for 4 hours. But, you know, we've taken people into supine, and 20 minutes later, the doc's saying, go back to prone, because they're decompensating. So if this has to happen at night, then we're trying to push the envelope so that time gets later and later. The ultimate time for proning is around 2 to 3 in the afternoon, so that they can go in prone during daytime, rotate during nights, and then go into supine back in day around 9 o'clock in the morning. So the ultimate time is 2 in the afternoon to 9. So if we have to eke it out an extra hour or decrease, we've got to talk to the docs about that to get back on track. You know, one of the docs said, well, she came from Denver, and I've done